It's a privilege to welcome you all to this dissemination event that will focus on COVID-19 awareness, preparedness, and impact on the most vulnerable groups among the forcibly displaced Myanmar nationals and the host communities of Cox's Bazar. This event is jointly organized by BRAC James P. Grant School of Public Health and the Center for Peace and Justice, BRAC University. The research project is funded by International Development Research Center, Canada. May I call upon Professor Sabina Faz Rashid, Dean BRAC James P. Grant School of Public Health, and Barrister Manzoor Hassan, OBE, Executive Director of CPJ, to welcome our respected guest in the next 5 minutes. Dr. Rashid and Barrister Hassan, all yours, please.
Thank you, Atif. Good morning. It's a pleasure to be here today. You know, I know that Manzoor Bhai and I waited, and all our colleagues, a long time to share some of the really, really rigorous research and a lot of the activities on the ground in the camps and host communities. I'd like to first of all thank very much our Mr. Muhammad Shamsuddoza, our additional refugee relief and repatriation commissioner. Thank you so much, Doza Bhai, because I know how busy you are. So we're very delighted you could make time today. I'd also like to thank Joe Landry, who has joined us. Thank you so much, Joe, because Miss Megan is unable to, there's an emergency. So thank you, Joe Landry from the Canadian High Commission for joining us today. I'd like to also welcome Edgar Rodriguez, who's been on this journey with us for quite a while now. So thank you for joining us from Delhi. Before you fly home for your Christmas break. Thank you so much. We're very excited to be part of this, and hopefully you can travel given the current situation with the COVID variant. And also we'd like to thank Dr. Anindya Chatterjee, who's Regional Director of IDRC. So this project really is a very strong collaboration between the James P. Grant School of Public Health, where we lead the research, and Center for Peace and Justice, that lead all the ground to contextualize activities which translate evidence into action, working with Rohingyas and host communities. This is really phase one, as Atif shared. It's really around their responses to COVID awareness, preparedness, and really the most marginalized vulnerable groups. And really the sharing today is about to give insights into these groups, how they've managed, and from CPJ, all the activities on the ground. I won't speak much longer. I'm going to ask Dr. Manzoor to take over, and maybe he can share a little bit. Thank you very much, and I look forward to having all of you join us for today's event.
Thank you. Thank you. Good morning. Good morning. Welcome. Thank you, Sabina. I think it's a very brief welcome from me. You have covered the main points. Just to say that we are delighted to have our chief guest, Muhammad Shamsuddoza, who has been the additional chief refugee relief and repatriation commissioner with RRC, office of the RRC for quite a while. He is very familiar with the work that we have been doing and has been a well-wisher of us, CPJ, and the School of Public Health. So we are delighted to have you, Mr. Shamsuddoza. We are also delighted to have with us our special guests, Edgar, and we also have a special guest from the Canadian High Commission. So we are delighted to have you. As Sabina has said, we have been actually working in partnership. And we have been, CPJ has been implementing some of the work at the ground level, but our colleagues from the School of Public Health has been actually undertaking some very interesting research. So we are going to be actually today sort of hear from our colleagues who have been working at the field level in what we have done. So we have very much welcome all of you to this event, and look forward to further interaction later on. So over to you, Sabina. Thank you.
Thank you, Barrister Hassan and Dr. Rashid. May I now call upon Dr. Edgar Rodriguez, the Senior Program Specialist at the International Development Research Center, Canada, for his opening remarks. Dr. Edgar, all yours.
Good morning, everyone. Assalamu alaikum. My name is Edgar Rodriguez, and I'm a Senior Program Officer here in Delhi at the International Development Research Center, IDRC, in our regional office for Asia. Our regional director, Dr. Anindya Chatterjee, present in the audience, will be addressing you later in the program. My job today is to thank the organizers, Professor Sabina Faiz Rashid and Mansoor Hassan at the Center for Peace and Justice at the University of BRAC, and the teams in Dhaka and Cox's Bazar for their great work and dedication in this undertaking. And I would like also to acknowledge and welcome our special guests, Mr. Mohammed Shamsud Dusa, the Refugee Relief and Repatriation Commissioner, and Joe Landry from the High Commission of Canada to Bangladesh. To them and to all the attendees, a warm welcome for taking the time to attend this session that deals with a crisis that we are learning to live with. COVID-19 pandemic has definitely changed our lives, turned them upside down. From what I hear right now from Sabina, it is going to definitely alter my Christmas plans. The pandemic has actually disrupted everyone and everywhere. It has also exposed and deepened the inequalities worldwide. It has, at the same time, opened new possibilities, such as renewing, in the case of IDRC, our vows for supporting local, high-quality, policy-relevant research in the countries in the South to defend and protect vulnerable populations through a number of innovative partnerships like this one, like the one we have now. IDRC has invested nearly $55 million in COVID-19 programming in more than 65 countries now. The results so far demonstrate that these initiatives are producing crucial evidence that would really support to give solutions to a wide range of direct and indirect impacts stemming from the pandemic. The pandemic is, of course, a global challenge and will require a global response based on knowledge from all parts of the world. And building on our extensive network of researchers, IDRC has put in place a number of initiatives that reinforce each other. And that all these initiatives together are providing a wide range of results. Just to name a few, the research has generated recommendations and policies for practical measures that would strengthen food production, livelihoods, and social safety nets to ensure greater food security in the time of crisis. Also, research on COVID and education has documented very serious and unexpected social outcomes from school closures in Africa, such as pregnancy increases among schoolgirls, and it has offered better ways of responding to future disruptions. We have part of the initiatives that we are funding have also pointed at artificial intelligence, which is playing a pivotal role in pandemic public health decision-making in several countries across Africa. At the center of predictive modeling and forecasting research is the creation of artificial intelligence and data-powered dashboards, which display locally relevant information for the public and the policymakers in several countries. So the number of initiatives that we have in place, one of them is the one that brings us together today, and it's the one called COVID-19 Responses for Equity, or CORE, C-O-R-E. This is where this Bangladesh project sits. And this core initiative aims to support research that not only seeks to understand the impacts of the pandemic, but also looks at the community level responses to the pandemic. And through a cohort of projects in Bangladesh and elsewhere, is looking at an important component, important aspects of how the pandemic is affecting the life of forcibly displaced people. In IDRC, in the program where I am now, which is the Democratic and Inclusive Governance, we do care tremendously for migrant populations. And the research has shown that there are structural barriers that are actually hindering the access of these populations to social protection. We have a number of structures in government that exclude these transitory populations from accessing relief and benefits. And these barriers are sometimes manifested in the form of identity documents, for example. So we have examples from Latin America where, for example, in Mexico, workers from the city are more likely to receive cash transfers simply because they have access to ID. And a similar phenomenon is documented in the case of India, where migrant workers in the cities of Ahmedabad and Delhi could not access food relief because their ration cards are registered in their home cities and not in the cities they're living today. So examples like that are in abundance in Latin America and are being documented through this initiative. And another aspect that we care about very much at IDRC is the fact that most of these migrant populations face social exclusion, which is intensified by intersecting aspects of the identity of migrants, such as gender or ethnicity. And for example, the pandemic has increased disproportionately the burden of care work that women undertake, especially during lockdowns, and is affecting when the lockdowns affect the functioning of schools or the daycares or the informal support provided by grandparents and other family members. So today we're going to hear a number of these gender effects that have been documented by the project by BRAC University and the Center for Peace and Justice. So I won't be stealing their thunder, and having said this, I would like to welcome again our guests and speakers, and to keep up the idea that this project is embedded in a belief that state-level responses can become more successful to address needs for migrants when interacting with community-level responses. That seems to be an aspect of great interest that is emerging from the research that is being conducted. So without further ado, I would like to give back the floor to the organizers. Thank you very much.
Thank you, Dr. Rodriguez. Please join hands with me in welcoming our chief guest, Mr. Mohammad Shamsuddozza, Additional Refugee Relief and Repatriation Commissioner to the Government of the People's Republic of Bangladesh. May I request Mr. Shamsuddozza for his speech. Sir, please.
Thank you. Thank you. First of all, I would like to thank you, BRAC University and all others for inviting me. The COVID situation and COVID management in Rohingya camp, I think in Bangladesh, the first COVID patient was detected in 8 March 2020. When we got the news, we sat on a meeting with our camp teachers, all officers and all other partners to see what we should do at the moment. Then we decide, several meetings happened, we decide, we took so many decisions. First decision, in 17 March, we issued a letter to stop all activity other than food, health and wash. The first COVID patient in that activity, I think less than 20% human resource moved to camp. And we got excellent result. After near about 70 days in camp, first COVID patient was detected in camp. Now it's almost near about, I think, 1 year, 9 months past COVID. Actually, so many intervention happened in camp. We established with the help of UN organization, other partners. Definitely, BRAC is working here, not BRAC University. We established SARI ITC and so many establishment already and so many testing facilities. And now what happened in the camp, we get a good result, and the first patient was after 70 days, we got first patient. Now almost near about 80,000 tests done in the camp. The result is some 4%. The COVID patient is more than 4%, 4.6 is 3,500. Any died is not actually good. In camp context, total 34 people died in COVID. Out of 1 million, 34 people died. Out of 34 in first phase, first wave COVID, 10 people died. And second phase COVID, 24 people died. In the early initiative, we took several measures maintaining. Though in the camp the density is so high, it is difficult to maintain the social distancing in the camp. so what we did, actually, we thought that those who are the we people who are going to each and every day camp, if we the Rohingya, the main carrier, if it is probably the main carrier of the camp, we who work in the camp. That's why we restricted camp activity, and after some days, and in the meantime, Bangladesh government gave lockdown. Before Bangladesh government, we contacted higher official. We implemented earlier in the camp. Now almost all activity now the COVID patient, you know that now the COVID test, we tested COVID, some days nil, some day 1 or 2. The test is result is now negative almost, and we opened all the activity, almost all the activity in the camp, but given some condition, how many people will gather in a room, how many some action taken by us and our partners. Thanks to all our partners, actually they maintain it properly, and we got the result. I think out of 10,000, out of 76 or 80,000 tests, is below 4,000 is quite good. I think we'll continue this type of work. If any, now we heard that any other Omicron and others variant are coming, then we will sit together. But in the camp context, this situation is okay now. And thank you once again for inviting me. If you have any queries, please feel free to ask. Otherwise, I will move to camp. I have another assignment in the camp. Thank you. Thank you for inviting me. Thank you, Manju sir. Thank you, Sabrina for us. Thank you, Bazar. Thanks, others. And thank you, BRAC JPSC. Thank you.
Thank you so much. Assalamualaikum. Khadafis.
Thank you, sir. Now we will hear a bit of overview regarding the project, followed by presentations from the project team members. I first call upon Ms. Basira Akhtar, Assistant Director at the Center of Excellence for Gender, Sexual and Reproductive Health and Rights, BRAC School of Public Health, for her presentation. Ms. Akhtar's presentation will be followed by a series of presentations from the project team members. Please note that my colleague...
Manzoor Bhai wanted to say something.
Yeah, sure.
Sorry to interrupt. Just to say that as Mr. Shamsuddoza will be going to the camp, I think I'd like to convey on our behalf very warm thank you to Mr. Shamsuddoza for gracing this event with his presence. And obviously we will keep him informed in terms of the proceedings today. And if there are, as he said, if there is any question to him now from any of our guests, he will be very happy to take those questions. So I think slight change to the program. I mean, if there are any questions from our guests, please put it to Mr. Shamsuddoza. But thank you, Shamsuddoza, Mr. Shamsuddoza, for staying with us. And let me just open the floor, Sabina, with your permission.
Yes, absolutely. I also wanted to say thank you so much, Doza Bhai, for gracing it, because we know how busy you are, how many things you're managing. So we're very grateful. Does anyone have any quick questions to?
Sir, thank you, Manju sir. If you have any question, already in the chat box, I gave my personal mail address and official mail address. Please feel free to mail me us. I will be trying to give any other answer. Thank you.
Thank you. Thank you. Thank you very much. Sabina.
Thank you so much. Assalamualaikum. Thank you so much. আমরা যোগাযোগ আপনার সাথে যোগাযোগ রাখবো অনেক ধন্যবাদ
Thank you. Assalamualaikum. Thank you.
Okay, thanks Atif.
Thank you, Sabina.
Thanks, Manzoor Bhai.
So I'll call upon Ms. Basira Akhtar, Assistant Director at the school, for her presentation. Please note that my colleague Muhammad Riaz Hussain will control the slides in the background for your convenience. Ms. Akhtar, all yours.
Thank you, Atif, and thank you again to our very distinguished guests for joining us today. We are very delighted to have you and share our experience of one of our research projects funded by IDRC. So as you see in the invitation card, today we are sharing some of our findings from the first phase of our research, which focused on COVID-19 awareness, preparedness, and impact on the most vulnerable groups among Rohingya and host communities in Cox's Bazar, Bangladesh. Next slide, please, Riaz. I'm very thankful to my previous speakers, Samsudullah Sir and Edgar, for setting up the background of the Rohingya, of the humanitarian crisis globally and also in Bangladesh. So I'm not actually spending much time here, and all of you already know that how COVID has brought challenges to this already fragile context. And there are many new vulnerabilities emerged due to COVID-19. And there are many reports are coming up actually regarding different gender-based violence, increased gender-based violence, increased child marriage, and the poor living conditions that some just mentioned already. This is also one of the factors that make all the efforts very challenging, and also the community people, it's very challenging to follow different recommendations or preventive measures to deal with and manage COVID-19. And the government of Bangladesh and different humanitarian actors were continuously and consistently trying to mitigate this impact of COVID-19 on this host community and the Rohingya communities. Next slide, please. So to support the government of Bangladesh and other humanitarian actors, agencies, and partners, the two institutes of BRAC University, James Freegan School of Public Health, and the Center of Peace and Justice, we have jointly taken an initiative to conduct and participatory action research with the support from IDRC. And the findings and the experience that we will be sharing from the duration of August 2020 to July 2021. During that period, we actually conducted the study and also implemented some community-based interventions as a pilot basis. So our target population was most vulnerable groups. I will come later about who were the most vulnerable groups. So we identified in our research, and also the humanitarian actors, policymakers, service providers. Next slide, please. So the overall objective of this first phase of research was to provide critical evidence to support the policies and interventions to mitigate an adverse impact of COVID-19. Especially among the most vulnerable groups. And we tried to understand the impact of COVID-19 on the vulnerable groups and the new forms of gender vulnerabilities among these both host and Rohingya communities. And we also tested out a community-based approach to increase awareness about COVID-19 preparedness, response, and safety measures. Next slide, please. So now I will briefly discuss about what was the focus of our first phase of research. So there are some, these 6 are the broader research questions that we tried to address through our formative and quantitative research. So we tried to understand that who are actually the most vulnerable groups. So there are many literatures regarding that, but sometimes we found that the literatures, some vulnerable groups who are sometimes are not that visible, they are left out from different programs, different researches. So we actually try to understand communities' perspectives, their point of view, how they define vulnerability, who are the vulnerable groups and why. And we also try to understand the new forms of vulnerabilities that the COVID-19 has brought, and the impact and the local, social, and economic understanding of the COVID, the people's knowledge, their perceptions, and their healthcare seeking behaviors during pandemic. And as you can see that from our title, that our overall objective was actually to understand the impact and how these vulnerable groups are suffering, they're surviving in this COVID situation, and how they're following and what are the challenges of following different precautionary measures. And we also have developed a gender-based vulnerability index which my colleague will discuss later. Next slide, please. Riaz, are you facing any difficulty?
No.
Okay, please. So this is the overall research design. of the first phase of our research. So first, we did actually a very comprehensive and intense literature review to understand what is available in the literature and to formulate our research questions, to design our study, and also to get some idea about the vulnerable groups the research, different literature is suggesting. Then we conducted a research design workshop with the partners working in the Cox's Bazar, who are actually directly providing services to these both communities. And maybe many of you were participated and joined us in the research design workshop. And then we did some qualitative assessment that we call formative research in both host community and Rohingya communities. So you can see from the slides that we actually applied different qualitative methods to triangulate, to understand, to get in-depth understanding about vulnerable groups and vulnerability and their impact of COVID-19 on their lives. And after the formative phase, based on the findings, based on the experience of formative phase, we designed a household survey. And we conducted household survey in 10 FDM camps. And we interviewed more than 1,028 households. And in the host community, we conducted the survey in 8 wards in Rajapalang Union, and we interviewed 1,036 households. Why I'm saying households? Because our main unit was households, because we wanted to understand what are not only the people who are most vulnerable, but the households are also having or facing negative impact of COVID-19. And in each household, we selected the household in that way that at least one members from the most vulnerable groups are belong to in that households. And after that, we also conducted another round of qualitative assessments to get more in-depth understanding of some of the issues that emerged in our survey. And we did that that qualitative assessments in, again, that FDM camps and Rajapalang Union. Next slide, please. So now I will briefly share how we actually come up with this list of most vulnerable groups. As I mentioned earlier, that we did literature review, we conducted a research design workshop, and also our research team visited field, both host community and also the FDM camps, did or conducted some informal interviews, did observations to get more perspectives from the community about their understanding, their definition of vulnerability and most vulnerable groups. And finally, we have come up with these 5 categories of most vulnerable groups: elderly, pregnant and lactating mothers, adolescents and youth groups, and persons with disabilities, and single women household heads. Next slide, please. Another component of our research, this participatory action research, was community-based COVID-19 awareness. So our partner, Center for Peace and Justice, they did some activities in the community level, and they focused on the most vulnerable groups that identified from the research. And based on our research findings, our partner CPG has designed the community-based COVID-19 awareness activities and also training module. Next slide, please. So what our partners did, so at the community level, they selected 10 volunteers in the host community and 20 volunteers in the FDM community. And they also developed a training module on COVID-19 awareness, on facilitation of community-based outreach and workshops. And those volunteers were trained on facilitating those outreach workshops. And they conducted outreach workshops every month in the community level. And this, because of the, with respect to the cultural norms and practice in the community level, our youth volunteers conducted workshops, community-based community level workshops for male and female participants separately. And before the lockdown and after the lockdown, they facilitated and arranged these workshops in person. But during the lockdown and mobility restrictions, our partners also tried to do some remote awareness activities over the phone. Okay. Next slide, please. So now I would welcome and request my colleague, Dr. Safiqur Rahman, to discuss and share about our gender-based vulnerability index. Thank you, everyone. And if you have any questions, please feel free to write in the chat box. We will have we will try to answer in the chat box. Thank you.
Okay, so thank you, Bachara. And okay, so this part will introduce one vulnerability index, which actually we develop under this project for assessing the intensity of vulnerability in the humanitarian crisis. You know that already we discussed the population we are talking about now. So these population have a multidimensional pre-existing vulnerability. And the current pandemic situation makes the population more vulnerable, and particularly we identified some vulnerable groups already discussed here, 5 vulnerable groups. So we try to develop a vulnerability index which will help us to scale. I'm mapping the household, like that the household is the most vulnerable, household is the least vulnerable, household is the medium vulnerable, household is the low vulnerable. So we can assess the intensity vulnerability in a scale from low to and makes a high vulnerability. Okay, so this type of analysis or vulnerability index will help the policymaker, international agencies to formulate necessary policies and intervention required for these MBG groups, so to address the vulnerability and to improve their livelihood. So next slide, please. Okay, so now in this slide, I'm talking about how we develop this gender-based vulnerability index. Basically, you know that vulnerability is a multidimensional approach. So that means it depends on the multidimensional themes which lead to the livelihood of this population. So based on the literature and the other I mean the researcher who developed the vulnerability index in kinds of such kinds of the humanitarian crisis in this population. So we selected 9 themes which are actually related to livelihood. So demographics is one of them. So in this demographic, under the demographic thing, we consider 3-4 indicators, which is how many people. I mean, this includes the number of MBG group in the one household. So based on actually we transfer the data and household level. So each one household, if you have more than one vulnerable MBG group, so we can consider is the more vulnerable. So it's less number of vulnerable is the less. So and the dependency ratio is another indicator. So education, access to income, and food security. So household during the COVID pandemic situation, you know that the food is one problem. I mean is a major issues. And support service during the COVID pandemic is another themes. So in COVID pandemic situation, people either receive any support to mitigate the COVID condition, pandemic situation. So water, sanitation, hygiene is the basic needs of the any kinds of any population. So and the health is another issue. So access to the health facilities or service during the pandemic situation, either interrupted the service or not. So we consider such kinds of indicator under the health theme. Access to basic services like the birth registration or death registration and some government facilities which are allocated for the elderly people or disabled people or single female and household or adolescents. So these services are included, and security is another issues in the Rohingya community and in the adjacent host community. So we developed, under the 9 themes, we consider 44 indicators. So basically, I cannot show all the indicators here because they're very is a long table. So actually, all the indicators we coded in a ordinal scale, which is that means to understand the increasing the values of the indicator, increase the level of vulnerability. For example, if you have the binary indicator, so we consider the 1 if the service is not available. So we consider if service are not available or deprived of the service, we can consider the vulnerable. And if the service is accessible or available to the population, so we can consider the no vulnerability. So statistical method we apply. So there is 44 indicators under different 9 themes. So we applied principal component factor analysis to generate the index. So this is actually a linear combination of the 44 indicators. So under this linear combination, we can generate a score, and the score it was rescaled to 0 to 4. So 0 to 4, that means to rescale to 0 means the least vulnerable household, and 4.1 was the most makes the most vulnerable household. So class 3 groups. So based on the scores, so 3 groups: low vulnerable groups, medium vulnerable, and high vulnerable or acute vulnerability. Next slide, please. Okay, so you can see here some results of the vulnerability using the vulnerability index. You can see the intensity of the vulnerability. We produce the results separately for the abdomen and host community. 0 to 4, so 4 is the most vulnerable, or so you can see here the 3 groups: low vulnerability, medium vulnerability, and acute vulnerability. You can see here in the abdomen community, most of the people belong to the acute vulnerability. That means most of the people are more vulnerable than the abdomen community than the host community. Host community, a minimum number of household belong to the acute vulnerability. Most of the household belong to the low vulnerability. So we consider the another indicator, which either the household belong to the host community or household belong to the abdomen community. So if you see the right side of the bars, you can see the red ones, acute vulnerability. So almost 65% of the abdomen or Rohingya household is belong to the acute vulnerabilities. It has been in terms of intensity vulnerability, acute vulnerability, very high vulnerable. So you can see here in host community, the most of the household low vulnerability. So all people are vulnerable, but we can see here the actually which people are more vulnerable and which people are not less vulnerable. So next slide, please. Okay, so then we try to relate with the vulnerability scale with our MBG. So 5 MBG group we identified at the beginning of the research, and we sample the household interview of those households which have at least 1 MBG. So that means there are 5 MBG. If you see here the red bar, which is acute vulnerability, you can see here the single female-headed household is have the most highest number of acute vulnerable. So, and you can see here the pregnant and lactating women is a less compared to the other vulnerable groups who have the less proportion of the acute vulnerability, which is followed by adolescent, elderly, and people with disability, and the single female head household consider the highest number of acute vulnerability. So you can see the next slide, please. Okay, so and then we try to relate it to the if we identify the most vulnerable groups, so acute vulnerable group or low vulnerable groups, so you can see here the basic says facility-based delivery. If you consider facility-based delivery or ANC service, you can see here the acute vulnerable people getting the less proportion of the facility delivery and ANC service compared to the low vulnerable people. And if you can see the elderly allowance and elderly people for their allowance, so you can see here the acute vulnerable people are getting the less number of the less proportion of the allowances, and you can see here the allowance for the people with the disability and adolescent education stop for the acute vulnerability is highest number, and single female-headed household they have some allowance from the governments or other facilities for widowed or divorced allowances, so which is you can see here the acute vulnerable people are getting deprived of getting the essential service allocated for them. So these are the preliminary findings. You can the next slides. So using the vulnerability index, we can assess identify or map the household with the most vulnerable, less vulnerable, or medium or low vulnerable. You can see here the intensity of vulnerability is higher in the abdomen community compared to the host community. And we can find the single female household are relatively more vulnerable than the other MBG group, which is followed by the people with disability and elderly. And household with acute vulnerability often deprived of receiving essential allowances allocated for them. So these are our initial findings based on the vulnerability index. So this is, I can finish here my presentation. So I think the next, my colleague will present the next slide. Thank you. Rafia, you can continue.
Okay, let me try to unmute Rafia.
Hello and good morning, everyone. My name is Rafia Sultana. I'm a senior research associate working for BRAC James Pibrand School of Public Health. Due to some technical difficulties and my ill health condition, I apologize for not being able to turn on my video. Hope that would be okay with all. I want to welcome you all to this presentation today, where I will be sharing some of the findings on the impact of COVID-19 among the most vulnerable groups in the host community. In the coming slides, initially, I will discuss the perception of COVID-19 and COVID-19 vaccination, community practices regarding the COVID-19 safety measures, and then I will share some of the recommendations we got from the community people regarding the COVID-19 information dissemination. And finally, we'll share about the impact of COVID-19. Next. So in this slide, I would like to briefly share how the community people perceive the COVID-19 and the COVID-19 vaccine. We found out that most of the respondents perceived COVID-19 as a curse of God, as in something that came from God as a punishment upon his followers because of their misdeed and sin. Some of the elderly respondents shared that the COVID-19 is basically a propaganda spread by the non-Muslim communities to stop the Muslims from praying to God. Additionally, when the respondents were asked about the symptoms of COVID-19, majority of them reported about having fever, dry cough, and sore throat as the COVID-19 symptoms. Lastly, most of the respondents shared that the community people considered death as the ultimate outcome of the COVID-19. Also, from our household survey, which noted responses from 1,036 respondents, measured people's knowledge about the COVID-19 vaccination. So we found out that about 82% of the surveyed respondents had heard about the COVID-19 vaccine, mostly from the TV, newspapers, their neighbors, and social media platforms. So among them, 96% actually showed their interest in the vaccine. However, their intention to take the vaccine were different from male to female. The female respondent expressed willingness to protect their children and family, while the male respondent shared that they would take the vaccine only if it is mandatory to take. Next slide, please. In this slide, we are looking at the practices regarding COVID-19 preventive measures in the community. The survey data showed that one of the most commonly reported preventive measures, among others, was keeping home clean. More than 50% of our respondents were not aware about the proper hand washing technique recommended by WHO. Additionally, in the survey, from our survey, our respondents were asked about the frequency of their mask wearing practices. And around half of all respondents across genders reported that they always wear masks. However, in our qualitative study, we found out that people were reluctant to follow any safety measures as the fear of COVID-19 was reduced since the lockdown was lifted. Additionally, few male respondents shared that they wear masks in public places due to the fear of the police And the elderly respondents shared that they only wear masks while going to the mosque due to the encouragement from the imam. Next slide, please. So regarding the COVID-19 information dissemination in the community, radio, TV, friends, relatives, and newspapers were the most popular sources of the information for our respondents. We also asked the respondents regarding who they considered as the trusted people in the community, who would be influential and beneficial in creating awareness about COVID-19. So the males, including adolescent, adult, and elderly, mentioned about the religious leaders such as imam and khatib, and also about locally elected government officials such as Upazila Nirbahi officer, Union Porishad chairman and members. While as the female groups respondent preferred community health workers. Our research also analyzed the respondent recommendations regarding their preferred times and place that required consideration while planning any awareness activities in the host communities. So the adult males shared that the after prayer hours on Friday outside the mosque were their preferred time and place. The adult females believed that the morning hours from 9 to 11 would be feasible for them, as that is when the men are out for work and the females are alone at houses. The PWDs and the adolescent girls shared the same opinion as that of the adult females. However, boys preferred afternoon to evening times, just before the dusk, near the playground, as that is where they meet regularly. Next slide, please. So in the coming slide, I will share about the impact of COVID-19 in 5 categories, which are social, economic, food security, mental health, and their health-seeking behavior. And in this slide, I will discuss about the socio-economic impact of COVID-19. So from the research, we found out that COVID-19 had impacted the regular social life of the community people. In our survey, around 96% of respondents reported their inability to go to the mosque, temples, and churches, host or attend any marriage ceremonies, and not visit their neighbors, relatives, and friends. Also, around 87% shared that they did not even go to the typical marketplaces during the lockdown. That actually impacted their regular social life and social relationship. To understand the economic impacts of COVID-19, the survey respondents were asked about their jobs and household income status during pre-pandemic and pandemic periods. And we found that around 69% reported a decrease, while 11% reported a complete loss of their household income. This led to reduction of their household expenditure and also increased people taking loans. Next slide, please. So regarding the food security, we found that the household income loss had a direct impact on the regular food consumption level of the community people. The survey found that almost 69% of respondents reported a decline in food consumption compared to their pre-pandemic period. They reported that they had to skip meals on average for 22 days due to the lack of money to buy food. And also around 65% of households reported running out of food. And because of this food shortage, they had to eat less food, borrow money to buy food, and borrow food from their neighbors and relatives. We also found that COVID-19 impacted the mental health of the families who went through this food shortage and experienced household income loss. Such households mostly tended to be in more stress and tension. As the survey data shows that around 43% of respondents reported feeling depressed at a frequency of several days, which led them to have poor appetite or overeating problem, trouble falling asleep, or difficulty concentrating on regular things like before. Next slide, please. In terms of the impact of non-COVID health-seeking behavior, around 75% of survey respondents reported having at least one ill person in their household. However, their access to healthcare facilities was reduced during the lockdown. So according to our respondent, there were several reasons behind this. So some respondents mentioned that throughout the lockdown, doctors and medical staffs were frequently unavailable in health facilities that encouraged them to seek care from informal health providers like both those who were always available on that specific time. Additionally, some respondents expressed their dissatisfaction with the behaviors of the doctors or medical staffs. For instance, as they reported that the doctors did not properly attend to them and spoke to them from a distance. They did not touch them like before the pandemic, so which they perceived as unsupportive and uncaring behavior. So also the transportation cost was quite high during the lockdown, which also was unaffordable for many families. So these are some of the key reasons that discouraged them to visit healthcare facilities. Next slide, please. So with this slide, let me present how COVID-19 impacted the lives of the most vulnerable groups, which include single female household heads, persons with disabilities, pregnant and lactating mothers, adolescent and elderly. Let me start with the single female household head. From the survey, we found out that around 62% of the single female household heads that we interviewed reported a decrease in their income, and 20% of them said that their household income stopped entirely during the pandemic. Around 78% reported a decline in their food consumption, while only 14% received that they received some form of ration, which was not enough for them, as reported by our respondent. So during the qualitative interviews, many single female household heads mainly shared stories of their financial hardship during the lockdown, as many of them lost their jobs and were unable to find new employment due to the scarcity of livelihood opportunities in the community, especially for the females. Many reported having to starve or skip meals so that their other family members could have 3 meals a day. Next slide, please. So looking at the situation of the person with disabilities, from the survey, we found that lockdown impacted their mobility, as 25% reported that frequency of going outside was not much. 34% reported never going outside during the whole lockdown period. Around 77% of the PWD respondents reported an impact on their daily lives, that impacting their treatment seeking behavior, household income, and their socializing opportunities. Over half of them reported concern about their physical health regarding their regular health condition and fear of contracting with the COVID-19 disease. So during the interviews, the majority of the PWD respondents shared their struggle in terms of availing the health services. This was because their caregivers, they did not want to take them to the hospital, as the caregivers thought the hospital could be the areas from where they could be infected. And due to this reason, sometimes the external caregivers, which are basically from their community and their neighbors, they demanded extra money to accompany them to the hospital. This coupled with the long waiting hours in the hospital, which actually difficult for them due to their physical health condition, as reported by one of our PWD respondents. So in the household survey, around 38% of respondents reported a disruption in availing postnatal care services. The reduction in available PNC services was 1.3 times lower than that of ANC services. Around 40% of respondents had to go for the home deliveries during the lockdown. From the case studies, we explored some of the reasons behind the service disruption, as few pregnant and lactating mothers shared that this was because only a limited number of hospitals and provided healthcare facilities for pregnant women during the lockdown. They specifically complained about the dissatisfactory behaviors of the doctors and medical staff, which discouraged them to go to the facilities as well. Next slide, please. Yeah. So From the survey, we found out that as of January 2021, 75% of adolescents reported that the educational institutions were shut down during the pandemic, which put a stop in their education. Also, around 13% of the respondents reported that they were continuing their education via online platforms. Well, only 6% were continuing with the help of a home tutor. In the case studies, a few girls expressed their fears regarding forced marriage. This was because their families were suffering from financial difficulties, and to lessen the burden on the families, parents moved them to marriage. Next slide. Yeah. So regarding the older adults, from the survey, we found out that overall 2/3 of elderly respondents in the host community believed that the pandemic had created problems in their daily life. Though more than 90% of the elderly respondents had taken special care during the lockdown, still their biggest concerns were related to their restricted mobility, their household income loss, and their family's well-being. Basically, they were worried about their family members who lived abroad, because they heard that the death rate was quite high in the foreign countries. So in the interviews, many respondents shared that they were aware of the risk of the disease to their age group, and that made them extremely vulnerable. They felt this way, and this led to lack of sleep at night, extreme fear and anxiety and restlessness. So that's all from my side. I want to thank the whole team for their support during the research, and over to my colleague, Kazi Samin Nasir. Thank you. Thank you all.
Thank you, Rafia. Good morning, everyone. I'm Samin Nasir. I'm working as a senior research associate at the BRAC James P. Grant School of Public Health. I'll be presenting findings on the FDMN community on the impact of COVID-19. So similar to the host community, they also termed COVID-19 as God's curse. Some adult male FDMN members also believed that it would only affect non-Muslims. And this kind of resulted in theorizing about its origin, as with this quote, which we found from the qualitative studies, that I heard that people died from corona in China. They threw bodies in the ocean. Then they ate fish of the bodies and became poisonous with corona. So I don't eat fish anymore. The majority of FDMN households reported that contact or touching, sneezing, and coughing were the main ways of transmission. And with regards to symptoms, most reported fever, dry cough, sore throat, and runny nose. More than half of the households also did not hear about the COVID-19 vaccine, but if over 90% were willing to take the vaccine if it was provided by the government. And some adult members still believe that the vaccine is only for the ill. So for example, this day laborer who believed that it was only for someone who has the disease. Next slide, please. With regards to the practice of COVID-19 preventive measures, the survey data, we asked them what were their most reported practices, and their top practices were drinking hot water, washing their hands frequently, and wearing masks. And the primary sources of information regarding COVID-19 and prevention measures were miking in the camps from local NGOs and international NGOs, and through friends and relatives. So majority of the respondents knew that wearing a mask was effective, but more than half of them admitted to not wearing their masks. And some females expressed like extra frustration as they already had to wear niqab or hijab. So it seemed like an additional burden. And other males complained that it was uncomfortable, especially laborers who work during the day and outside in the sun. Next slide, please. With regards to COVID-19 information dissemination, we asked them their initial sources of information. So you can see in the bar graph, most of them got their information from miking, then from NGOs, and then friends and relatives. With regards to their preferences, we asked each of each of the respective groups in our study. Adult females preferred door-to-door visits by community health workers and miking by CIC offices, and they preferred these visits or announcements before. Also, miking is mic announcements. There's a question from Joe Landry. So miking is mic announcements. So the camp office usually has speaker microphones all around, so they make public announcements. So they prefer this before 10 a.m. as after 10 a.m. their chores take over the day, and they're usually preoccupied by cleaning and cooking. With regards to adult males, most of them prefer table meetings with other community members in common meeting places, usually outside the mosque or near the water wells. So this is their preferred times were between 4 and 6 p.m. So this was usually after work, after the afternoon prayer, and right before the late afternoon prayer. With regards to preferences by adolescents and youth, most of them preferred social media messages, especially WhatsApp. Majority of them had WhatsApp on their phones during the time of data collection, and they preferred receiving these messages after 12, as they usually have lessons or homework which they attend to in the mornings. Next slide, please. With regards to the overall impact of COVID, as already mentioned, it's been separated into 5 different themes. So with regards to social impacts, mostly people were unable to go pray at the mosque or temple, and they were unable to attend marriage ceremonies or meet their neighbors and relatives, and couldn't also socialize at marketplaces. And this also kind of had an effect on many people's, especially elderly people and disabled people's abilities to source rations. So an elderly female said she had to struggle to bring food on to her plate, as no one would help her, and she'd have a lot of difficulty sourcing her rations from the camp offices. With regards to economic impacts, majority of households reported no change in their livelihoods, and 54% reported that there was no change in household income. But there was a small, around quarter of them reported there was a small reduction in household income, and 19% reported a complete loss. And this resulted in them having to reduce their expenditure, and some of them had to take loans. So this especially affected households where there were working members. So from our case studies, we can see there was from a 22-year-old unemployed male, like who was employed before the lockdown, thought that it would change after like the lockdown protocols were lifted, but there was a hampering of their job situations. Next slide, please. So with regards to food security, over half of them reported decline in food consumption levels. And with regards to skipping meals during the lockdown period up till January 2021, an average of 26 days where one meal was skipped in the household. 65% of households also reported running out of food due to a lack of money at least once. And to deal with these food shortages, 70% reported borrowing food, another 66% eating less food, and 56% they had to borrow money to buy food. So, and with regards to mental health, we used a validated scale, which is the PHQ-9. We omitted some of the statements as due to the sensitive nature of the field, but the major findings were with regards to trouble falling asleep, which was highest over the frequency of several days, and reporting feeling depressed or trouble concentrating on things such as regular things such as reading the newspaper or watching TV. This was also over the frequency of several days. And next slide, please. In terms of health-seeking behavior, at the time of the survey, 75% of the FDMN households reported at least one person ill in the household during the survey. And some also reported seeking additional consultation, spending an average of 119 to 20 taka on consultations and buying medicine, which was an average of 1,370 taka, and some diagnostic tests when they could go outside of the camps. But most of this treatment was sought from informal providers and informal pharmacies. Some FDMNs reported to us during the qualitative interviews that they did not seek treatment as they feared testing positive for COVID-19. This would force them, as they feared that if they did test positive, it would force them away from their families in order to maintain isolation protocols. Also, there was a fear of contracting COVID-19, prevented many respondents from visiting health facilities, despite them having some continuing ailments. Some respondents also expressed that there was they were disappointed with the behavior of some of the health service providers. A 27-year-old FDMN homemaker, she reported that if we could go outside of the Ukia and Cox's Bazar camps to see doctors, they would, but since they couldn't during the lockdown, they usually don't go, and they don't go outside of camps. But their main complaint is that they don't listen. They don't listen to them, and so what's the point of going there? Next slide, please. With regards to single female household heads, almost 60% of these households report that their household levels of income was the same as before the pandemic. For those that where levels of income had decreased, coping mechanisms were spending less money, government support, and receiving support from private philanthropies or charities. Only 2% of these households managed to save money during this period. Though FDMNs do get rations from the World Food Program, this is not always sufficient for every household, and around 80% of households could not stock up on food prior to the crisis, and this was mainly due to the lack of money. And another pressing concern, which we also found from our case studies, was that the lack of adult male members in single female headed households hampered their ability to source extra food, as at times without an adult male member, they were unable to go to the local markets or even the camp distribution points to source extra food. So this created additional problems in the single female headed households. Next slide, please. With regards to persons with disabilities, majority of them reported that they did not go out as not much and or never. 60% of them reported a significant impact on their daily lives, which mostly the main areas were seeking treatment, collecting rations, or socializing with neighbors or friends. So we have from the case studies, there was a 65-year-old male who reported that before the lockdown, there was members that would help him bring rations, either his neighbors or friends. But due to the lockdown protocols and the fear of the virus, no one would help him bring his rations. Therefore, he would have to struggle. And with regards to their most reported concerns, the top 3 most reported concerns were worries about their finances, physical health, and the well-being of their family members. Next slide, please. With regards to pregnant and lactating mothers, only 9% of pregnant or lactating mothers reported an effect of on the uptake of maternal health services. Over 90% of them availed ANC services, and 70% received PNC services. And home deliveries continued, with 63% reporting home deliveries at the time of survey. Next slide, please. At the time of the survey, 74% of FDMN adolescents reported a stop in education, and only 1% had access to online education. Some adolescents reported continuing their education with a home tutor, and 6% reported continuing their education at madrasas, which are religious Islamic schools, in the camps during this period. Female adolescents, from the case studies, we found that female adolescents had going to health facilities unaccompanied was looked down upon. So this hampered the ability, their ability to assist their household members in times of emergency. Adolescents were also aware of the struggles in the households, such as their parents losing jobs. Some adolescents had to assist their families, which proved difficult during the lockdown. So a 16-year-old female expressed concerns about money and how to earn money, and the effects on their food and nutrition. Similarly, similar to the PWDs, the elderly, 76% could not avail normal transport, and this also affected their ability to seek care, visit friends and relatives. 84% of them they reported receiving some form of personal care, which was in the form of personal protective equipment, food, and medicine supplies. Less than 50% of them believed that the pandemic had created problems in their daily lives, but close to 2/3 of them reported a significant impact, which again was mostly related to seeking treatment, for work, and collecting rations. So again, their main concerns were their physical health, finances, and worries about their mental health. With regards to sourcing money, a 68-year-old elderly female, she told us during one of our interviews that I didn't need money for the hospital before. During the lockdown, I had to pay 400 taka to get my medicine, which I could collect from the hospital without money before the lockdown. Therefore, I was left with no other choice but to beg from my neighbors to collect money for my medicine. So this is a result of times when hospitals or like health facilities ran out of medicine supplies, and often they would have to go to other pharmacies and they'd have to collect money to get this medicine. I would like to give the floor to our project coordinator, Bazar to present the overall recommendations.
Thank you, Samin. So based on our research findings, we have come up with 3 broader recommendations for both Rohingya and the host communities. So the first recommendation we would like to make is clear messaging. So we have found in our research that there are some misconceptions in both communities about the COVID-19, and although different agencies, different service providers are providing messages, but those messages were not clear to them. So it's very important to develop the messages which can also address the social, religious behaviors and beliefs and other contextual factors that we presented in our findings. And also it's the accurate and clear information on the importance and the need of maintaining protections and prevention guidelines is also important, as you can see from our research findings that there are some gaps and some misconceptions among the community. And we also recommend to involve and sensitize the trusted persons identified by the community. For example, in the FDMN, the trusted persons were religious leaders, imams, their majis, and CICs, and community health workers. And for the host community, it's imams, khatib, or government officials, Upazila Union Parishad chairmen, members, and community health workers. So in addition to the community health workers, we would also recommend to involve and train and sensitize the other trusted persons so that they can also disseminate information, and as the community trusts them, their retention of information will be higher, and they will also practice and follow the recommendations. And it's also important to also provide explanations of different messages. For example, when they're suggested to wear masks, why they need to wear masks, even if there is no cases detected in their community, even they haven't seen any deaths during data collection, but it's important to follow those measures. So it's very important to explain in simple local language so that they can easily understand. And many of our participants also told us that it would be easier for them if it is pictorial and video demonstration. So we recommend that different partner organizations or UN organizations, they can actually develop simple short videos on how to wear masks, how to wash hands, and the community health workers and the other actors can actually use those videos while they're disseminating messages or informing the community people. And the second recommendation is for risk communication on social media. As you see, especially in the Rohingya community, the young people and adolescents, they prefer actually social media. And interestingly, they have access to social media and internet. So we also recommend that this can be a potential good channel to disseminate COVID-19 related information, especially to reach younger generation. And the third recommendation from us is to targeted approaches for most vulnerable groups. So the targeted approaches, we means that, for example, the priority lanes and shorter waiting times for the elderly people, for the pregnant women and lactating mothers, for the persons with disabilities. And it's also important to give food and cash assistance, especially for the most vulnerable groups. We know that there are already food and cash assistance, but as you can see from our findings that it's inadequate to meet their needs, as they didn't have, especially during the lockdown, they didn't have any other ways to earn money. So they had to completely depend on some of the most vulnerable groups on the assistance, the food and cash assistance that received from government, from other agencies and organizations. So it's important also to focus on how that assistance can be, special assistance can be given to those most vulnerable households, especially with the single female-headed households and elderly people and persons with disabilities. And that's all from the research side. Now I'd like to welcome my colleague from CPJ, Center for Peace and Justice, to share some of our activities that our implementing partners did in the community level. Shaukat Bhai, over to you.
Thank you, Vatsnapa, for giving me the floor. Dear colleagues, very good morning. And I'm basically Shaukat Hussain, as Vatsnapa said, as the field coordinator of this project. And under this project, basically, we worked on a couple of issues, and we focused mainly on the raising awareness on COVID-19 in host and abdominal communities. Next slide, please. Okay, now I'm giving a small overview of this project, basically the intervention part of this project, just to understand why it was necessary and what was the basic modality of our activity. And after getting the research findings from James Pittman School of Public Health, CPJ basically developed a training module. And by the training module, we trained up our 30 community volunteers, 20 from FDMN community and 10 from adjacent host community, I mean from Rajapalong Union. So after train up, we basically made a trust audit so that we can identify the number of people in different households of our targeted area. And it basically helped us to reach out to them, even though we went with a number of challenges due to COVID-19. So we also made a very good partnership with community-based organizations in camp and also in host community. And we also disseminated some of the information with risk communication and community engagement team, CWC team, and C4D team, led by a couple of partners here in Bazar. So that was basically the background of our activities. Now I am going to give you some factual data and some information about our community activities and basically the figures of our community engagement activities. So CPJ volunteer facilitated 120 community level workshops on COVID-19 awareness in host communities. And by 120 community workshops, we basically reach out 1,140 females and 343 male participants. And in total, 1,483 people received information on COVID-19 and its safety protocols. So if we discuss more about the participants, we basically oriented 764 adults and 319 youths and 142 adolescents and 131 elderly people and 160 pregnant and lactating mothers, 100 persons with disabilities, and 15 single female-headed households. Next slide, please. Now I'm giving some figures of our community outreach activities of Rohingya communities. And our volunteers facilitated 240 community outreach workshops in Rohingya camps, and by 200 community outreach workshops, 1,312 female and 1,653 male basically were oriented. And in total, 2,965 people received information on COVID-19 and safety protocols. So, and in FDMN community is, I think the information I provided earlier, it was basically the information of the COVID-19. So similarly, in proportionately, we also reach out to the most vulnerable groups in refugee communities as well. So next slide, please. Now, as you know that this project basically implemented, the first work package of this project was a bit challenging for us because of some disasters, countrywide lockdown, and the COVID-19. So we faced a number of challenges. This include fire incidents and monsoon floods in Rohingya camps, disrupted our activities. Adapting alternative modality of workshops and trained up volunteers in changing reality, organizing workshops with strict safety protocols, instability in camps due to relocation of Rohingya refugees to Bashanchar and some security issues, increasing digital literacy among volunteers, as we basically tried to ensure the remote modality of workshops, and government restriction during COVID-19. Next slide, please. So the lesson we learned from community-based interventions are CPJ developed COVID-19 coping strategy that was very much important for all of us to keep our activities continued, and a strong trust networks developed in both communities, and a remote modality of workshop has been developed, and volunteers coped up with changing situation with mentorship, with capacity building activities, and inclusion of volunteers in digital platforms, and building a capacity of supporting staff to cope up with the changing situation. As you know, before we arrange any kind of activities in the field, we need to take a lots of preparation, and our supporting staff basically performed tremendously. So we also build up the capacity of our staff. So mitigating overflow of information in community level, as a couple of researchers from James Grant School of Public Health said that a number of organizations basically worked to mitigate the information gap in camp and host community, but we have seen the overflow of information, and the participants of our community outreach activities, they said that they received a number of information from different sources, but when we asked what is the basic strategy to keep yourself safe from the COVID-19, even though they were very much puzzled, and they had a number of misconceptions, prejudices, and so many things that basically most importantly, some of the refugees and host community people, they had some information how to keep themselves safe from the COVID-19. But unfortunately, many of them knew the strategy, but in practice, we found very few people who basically maintain the social distance, and who washed their hands, and basically they did not abide by the rules and regulations issued by the Department of Health of Bangladesh or international communities. So in practice, it was completely different. And that was basically our findings, and I would like to share one information with all of you that as I said that CPJ colleagues basically worked with the community volunteers, and they did a lot of emphasis on building capacity of the community volunteers. As a result, a number of volunteers have already got a very nice opportunity. For example, we have one participant from refugee community camp number 1 East. She got a chance to pursue her bachelor degree at the Asian University for Women in Chittagong. And Shamsa is here, so if we have any time, then we can welcome her to express herself as well. And also we have a number of ABMN and host volunteers who are now playing a very leadership role with a number of organizations, national, international organizations here in Cox's Bazar. So thank you, my colleagues, for giving me the floor. And I, of course, on behalf of this team, would like to give a special thanks to my CPJ colleagues. Thank you very much. Thank you. Over to you, Bazar.
Thank you, Shakhawat Bhai. Thank you, colleagues, for clear, concise, and explanatory slides. Thank you also for answering the questions in the chat box. We're actually a bit ahead, we're going to be overstepping the time 15 minutes. So may I request everyone to bear with us. Basically, the approach of this project was engaging with all stakeholders since the beginning. We have heard from the government representative, donors, researchers, and implementers. Let us hear from the community now. May I request Mr. Muhammad Abdullah, our community volunteer at Rajapalong Union of Ukhia sub-district in the Cox's Bazar, to share his reflections. Mr. Abdullah, please.
Hello, assalamu alaikum. Hello, assalamu alaikum everyone. I am Muhammad Abdullah from Rajapalong Union. Okay, I work as a volunteer in CPJ under the Idrc funded project Host Community to promote and raise awareness COVID-19 among the community people. Thank you for giving me this kind of opportunity here in front of all of you. To curb COVID-19 transmission, Bangladesh government declared nationwide lockdown March 2020. But when we started our intervention, we got to know that most of the villages people, especially those who are illiterate and have enough misconceptions, prejudices, and rumors on COVID-19. Most of them didn't believe that there is something like COVID-19, Especially religiously conservative people said that COVID-19 cannot spread among the Muslim peoples. Some of them used to say that lockdown is government conspiracy shutdown of our business. Participants shared how COVID-19 has adversely affected their physical, mental health, livelihood, education, socio-economic relation within community. I must say from my field level experience that adolescent, youth, elderly, pregnant and lactating mother, single female-handed household, person with disability are worse suffer on COVID-19. Most of the are suffer on the COVID-19 suffered. During participants, those who suffered from COVID-19 shared how they feel excluded during their isolation period and how it is had impact on their mental health, social relation as well. Moreover, participants shared how domestic source and gender-based violence have radically increased during the pandemic situation as male partners become jobless, spends more time at home. From my point of view, education sector has been adversely suffered on COVID-19 because of 18-month education gap had a huge gap for education system, for education student all of level. However, I feel very honored and blessed to be part of project through which we ever raise awareness and bring some positive changes community. Thank you. Thank you again.
Thank you, Mr. Abdullah. May I now request Shamsa Islam, our community representative from Camp 1E, to share her reflections. Ms. Shamsa, all yours.
Thank you so much for giving me this opportunity. Assalamu alaikum. Good morning, everyone. This is Shamsa from Camp 1E, Kutupalong. I work as a community volunteer at CPJ BRAC University. Under the Idrc project, we were assigned to understand concern and impact of COVID-19 in people's life and disseminated information of COVID-19. During the session, there were a number of Romas and religions prejudice around COVID-19 in Rohingya community. People hardly believe the existence of COVID-19. In our community, only people having enlargement or relation with some NGO, INGOs have some information about COVID-19. The vulnerability of women, elderly and person with disability has increased greatly during this pandemic. All learning centers, maktab, youth and adolescent club were being closed. For that, they don't have nothing to do, wasting their time. Women in our community have less access, education, knowledge, and information. They don't have any knowledge on COVID-19 and its safety protocol. They used to think that as they wear niqab, they don't need to wear masks. During our section, we have to put more effort to make them understand how important it is to wear a face mask, even if they put on a veil. When I see participants are maintaining COVID-19 safety protocol after attending our section, it makes me really happy. So I am grateful to CPJ for giving a chance to work for the betterment of our community. Thank you.
Thank you, Shamsa. I now request our special guest, Dr. Joel Landry, a senior officer at the International Assistance at the High Commission for Canada in Bangladesh. Dr. Landry holds a doctoral degree in international affairs. All yours, Dr. Landry.
Thanks so much. So I'm a bit of a late replacement here, and I don't have a long speech prepared or anything like that. I'm really heartened to hear the presentations that were given, and huge thanks to all of the research team, and especially to Shamsa and Abdullah, because I know it's really tough to get up in front of a room, even virtually, of a lot of people that you don't know and share your experiences. I think it's really important that we hear those voices from host communities and from Rohingya refugees, so that we can sort of get out of our bubbles and try to learn more about what's actually happening on the ground in the community. I do have some stats here, but I think it's kind of, always boring to hear people read off stats. So I think I'll just go talk about a few of my observations from the presentation. And just to say as well that we're really happy to see IDRC and BRAC working together, two of my favorite organizations in the world. And as a Canadian, very proud to have IDRC as a global leader in the development research space. And also on my day-to-day job here, I'm happy to let you know that I'm responsible for the strategic partnership agreement with BRAC. So I have an inside look at both organizations throughout the course of my graduate studies and now here in Bangladesh. So really, really happy to see that you're working together. So Canada has been a huge supporter of both the host communities and the Rohingya refugees. We have committed 82 million on bilateral development, Canadian dollars, over 3 years, and 124 million in humanitarian assistance over the last 3 years, I believe. So I'm really happy to see that some of the COVID interventions have been quite successful, and I was quite surprised to hear that only 34 deaths occurred. Seems very, very low, and I would love to hear people's pet theories or guesses as to why it's so low. It seems sort of like a miracle. I know that we have a lot of work to do, and of course, Canada is ready to support any additional work, and we are doing current planning. So I love to see that you did include policy recommendations, and I'm going to be taking those to my head of aid and to my head of mission as we do our planning for our next stages of support for this crisis. I really like the presentation. It was great to see the stats and the quotes sort of juxtaposed against one another, because I think a lot of the time we do forget that there are human beings behind every single one of these stories. And it's easy for us to see a stat, 1 million or 500,000 and sort of brush it off and not really fully comprehend what that means. I was really enlightened by the perceptions in the surveys. It's both enlightening for myself and shocking in some ways that some of the misinformation and disinformation and misconceptions have spread so widely. And I do think that the international community and the Bangladesh government and all of us that have a stake in this really need to think hard about how we can educate people without talking down and without creating rumors and this type of thing. I don't know the answer. I think it's a really tough problem because people always are going to believe people they trust. So I know that BRAC has identified some of the methods that we could use to help combat that issue, but I don't think it's not an easy problem. Just a couple of last points. I'm on the education and skills portfolio here at the High Commission, so I was quite interested to hear about the low online availability of education. I sort of knew that already, but I was surprised how low the percentage was. And I'd be really interested if there is more data on the early and child forced marriage aspect, because right now we're working on some additional projects and programming for improving girls' education and getting kids back into school to prevent early and child forced marriage rates from going up as they have been over the last year and a half. I think because of time, I'll probably stop there, but your policy recommendations are well taken, and thanks so much for everyone that put this together. Really, really happy to be invited and looking forward to learning more in the coming weeks and months. Thanks.
Thank you, Joe. I now request another special guest of ours, Dr. Anindya Chatterjee, Regional Director, Asia of International Development Research Center, Canada. Dr. Chatterjee, all yours.
Thank you. Thank you so much, Atib. Good morning. I think it's still morning there. Good morning, colleagues. Assalamu alaikum. Very happy to meet all of you online, particularly Mr. Manzoor Hassan, Sabina Pa, Bachira, and the whole team there. To me, it's a very significant presentation today for several reasons. Firstly, we are hearing the story of the Rohingya population, a population which has faced multiple vulnerabilities, violence, forced displacement, lack of citizenship, and now coping, surviving in the refugee camps in Bangladesh. this is quite important to understand what is how the population is coping. Secondly, from a research point of view, the study also looks at the host population, and therefore these two communities are sort of controlled for each other. So it's a very good design in terms of looking at it separately, maybe also together, but separately, as the study has done, and that gives us a sense of comparing against each other many of these vulnerabilities that you have documented so rightly. Thirdly, this is extremely important, of course, for Bangladesh. And I was hearing with keen interest about COVID's impact in people's life, loss of income, decrease in household expenditure, eating less, taking loan, significant impact on daily life in terms of social life, economic stress, significant impact on health and healthcare seeking, and impact on mental health, quality of life, anxiety and worries, depression, and all the rest of it. So, and most importantly, also the gender dimensions, how even gatekeepers, trusted members of the community who can access different genders and provide information, and that sort of granular understanding from the camps and the host community. So significant in that sense. And the recommendations follow right from what you have presented today. So, it therefore is very relevant. But more importantly, I think this body of knowledge that you are generating is very important for understanding what is happening with COVID. But it's also understanding, generating understanding of how communities are coping with COVID and what more needs to be done. Because as we know, COVID is here to stay, and displacement of population due to a variety of reasons is not going away. But these contexts provide, however difficult they are, they also provide some sort of a deeper understanding of how vulnerabilities of all of us in general, and how this is a shared responsibility of the humanity. I think this is leading us to that. To me, it is leading us towards that direction, and therefore, despite the difficult story that we were hearing, it gives me some hope that that this is a challenge of the global community, and the local understanding and data will help us to generate that commitment in the global development community. So thank you very much for taking all the trouble in reaching out to the community, to the refugee camps, going through all the gatekeepers and the system. I know it's not easy. I have some experience on the ground in Bangladesh, and I always said that yes, okay, there are problems, but Bangladesh also a place where there are solutions. And here is again, it reaffirms my belief that you have the solutions. So with those few words, thank you very much once again.
Thank you, Dr. Chatterjee. I would like to thank all dignitaries, researchers, implementers, government and non-government stakeholders for joining us in this informative event today. We are thankful to Mr. Shamsuddoza and the RRC office for their extensive support that aided the project's smooth operation. I would also like to thank our special guests, Dr. Joe Landry and Dr. Anindya Chatterjee, for joining us in this event and sharing their beautiful remarks. I'm indebted to the representatives from Bazar humanitarian response sectors who have spared time today and joined us in this event. I would also like to acknowledge Dr. Edgar Rodriguez for his lovely comments and the support from International Development Research Center. Lastly, I'm thankful to the project team members for their hard work and would like to congratulate them on making this event a huge success. With this, we would like to conclude the event. We would soon reach out to you through email with some fact sheets and research brief, hopefully next week. Thank you again for joining us. Have a great day ahead.
Thank you.
Thank you. Thank you very
Thanks so
much.
much.
Thank you
Great
very
job.
much.
Thank
you.
you very much.
Thank you. Thank you, Afa. Thank you,
Thank you
colleagues.
very much.
जी, Assalamualaikum, Afa.
Thank you, everyone. Well done.
Thanks, Edgar. I'll be in touch soon.
Yes.